I'm Chhavi Mittal. I'm a fitness enthusiast and a mom of two. But my biggest introduction today is that I'm a cancer warrior. Why? Because cancer has taught me so many new lessons, and it has also given me a second birth. Today I'm here to welcome you to Treat to Beat, which is part of our larger campaign, Sanjeevani, United Against Cancer. This initiative is all about having insightful conversations about breast cancer so that we can enhance the quality of life of all those who are fighting this disease right now. Joining me today is Dr. Pushpak Chirmade, medical oncologist at Kokilaben Dhirubhai Ambani Hospital. Dr. Pushpak is a super specialist in the field of adult and pediatric oncology, including chemotherapy, targeted therapy, hormonal therapy, and immunotherapy. He is a certified expert in Immuno-Oncology and Precision Oncology by Harvard Medical School, USA. He is one of the few oncologists selected for advanced certification in molecular oncology program by Sidney Kimmel Cancer Institute, USA. Doctor, a very warm welcome to you.
Yeah, thank you, Chhavi, to have me here.
First question, why did you choose oncology?
Okay, so it's a journey, probably, I'll say. To be very frank, my grandmother had a cancer. So I was in the second, third year of MBBS when she was diagnosed. And it was really taxing because at that time we are hardly oriented towards what it is, how things are going to be. We are just entering into the field of medicine. She's my maternal grandmother. She was a very strong support for our family. Why? Because my dad passed away when I was really young, and the family was held together by her. One day we came to know because she was losing weight. She lost excessive amount of weight and she was very frail. So we were doing many tests, but we did not get the results exactly to what was causing it. At that time, then when we did the CT scan, at that time PET scans were not available that routinely. So we did a CT scan.
How long back was this, doctor?
This was about maybe 2 decades. That is about 2005, 2006 ka time rahega. So we came to know that there were metastasis in the bones and all, and still we were never sure about what the primary cause was. So she took radiation, she took oral targeted therapy at that time, so which was quite costly back then. But that was a painful journey. So I actually did not want to become an oncologist because that I knew that it would be very daunting to take up oncology.
Okay, why is that?
Because every patient usually goes through all these ups and downs, and the only buoy or the support that they have is their doctor, right?
Right.
And it's a hell lot of responsibility to deal with a single individual cannot deal so much. That is what I felt back then, because probably I always thought that this is only or this is the way that a cancer patient goes. It is always that way. But then when I started learning more, I got my admission into my MD medicine. Then that was a conscious choice, because at that time I felt that the field was changing, and definitely there was something that could be of value. Right? Because it was an unmet need. What we were seeing that is the number of cancer patients were increasing day in, day out. Where I did my MD from, we had a very rudimentary cobalt ward, it used to be called. And at that time only radiation was one of the options that was available in government hospitals.
Okay.
Right? And it used to be full of patients. Nobody wanted to go to that ward because it was so mentally taxing.
Right.
And so definitely there was a thing and a thought process that over a period of time it would change, and probably we could be a mediator of that change. So probably subconsciously I think that was the driving force when I took up oncology.
What kind of change do you mean when you say
So
change?
availability of treatments,
Right.
accessibility of treatments, and advancements of treatments.
Okay.
Right? So I think all of them are very important, especially in a topography like India, where you have people of all stratas,
right?
Economic, logistical burdens and barriers are there. People travel from far off places and come to Mumbai. And trust me, the treatment cost is almost equivalent to the cost of staying here for these patients. And I think that will change, because now common people, we are understanding that it's a need of the hour that we tackle this problem, and there are collective efforts towards this. So I think that was one of the motivations why I took oncology, and I still practice oncology with that same zest and zeal.
But kudos to you, doctor, because somebody in your place, I mean, a normal person would feel that this is so taxing, and whatever you went through with your own grandmother and seeing one patient and the journey of that patient firsthand, anybody would feel that this is not something I want to associate myself with. I don't want to take other people's sorrow. But here you are. You actually went head on into the field, and you're doing such good work. So when you deal with these kind of patients who are in, maybe advanced stages of cancer, what is the treatment approach that you follow, and how do you decide it?
So see, every cancer is different. Okay, so over the last decade, we have identified cancers with the organs of origin. So we have already identified breast cancer, lung cancer. As we are going deeper into the research, now we are understanding that cancer is basically more driven by the molecular mechanisms, the pathways that control the body's cell division, the growth of the cells, how regulated they should be, and what mechanisms body has to eliminate. Because normally also these processes are there, but body has corrective mechanisms to eliminate them. So we are going into that era of precision oncology. Till now it was more organ confined.
What exactly is precision oncology?
So I would like to define it as like we identify the Achilles heel of why the cancer is caused. So imagine yourself, you are in a bus, you are a passenger. Now the entire control of the bus is in the hands of a driver, right? Even if you want to go to a particular destination, if the driver does not take you, you cannot go there, right? So this is something that the researchers have identified, and these are driving mutations, or these are changes in the cancer that can drive the growth of the tumor. Okay. So now what we have devised is that there are medicines that can identify and eliminate the driver, the basic source or the basis because of which cancer is developing, it's growing, it's spreading. So if we take an example of breast cancer, right? So breast cancer, like you also know, is of multiple types, right? So breast cancer is one type of cancer amongst many cancers, and there are multiple subtypes of breast cancer. So initially, maybe 7-8 years before today, there were classified as per hormone receptor positive breast cancers, HER2 receptor positive breast cancers, and triple negative breast cancers, right? So why do we do this classification? Because we want to find the pathway or the way or which is stimulating the growth of these cells. So if you have a hormone positive cancer, you will be on hormonal therapy. Or at least your treatment will include hormonal therapy as a part. It is one of the major supports to your treatment. So we are trying to identify and drive our cancer treatments by this thought process. This is precision oncology.
So basically identifying what is causing this particular cancer and then targeting that particular
mechanism. Yes.
That is precision oncology.
Correct.
And how do you decide, doctor, when a patient comes to you, that how many cycles of chemo or other treatment this patient needs vis-a-vis somebody else?
Correct. So whenever there is a suspicion of cancer, there are two things that are of prime importance that I tell to all my patients also. One is the type, like we discussed, the type of cancer or the subtype of cancer. And the second is the extent of cancer. How do we come to know about this? One is by doing a biopsy. Biopsy and certain molecular or IHC, immunohistochemistry tests to identify the type of cancer. And the extent is known by imaging investigations like, say, CT scan, a mammography, or a PET CT scan. Now, these two are the major deciders as to how your treatment will happen. So, if you have, say, for breast cancer, you are in not very early and not very advanced stage. You are somewhere in between. So, that is typically known as locally advanced breast cancer.
Okay.
Okay. So here, if you operate, you are not very sure you will be able to remove the entire thing or maybe do justice to the surgery. And research has also supported that idea. So here, probably we will resort to shrinking the tumor first.
Okay.
Right? We will give systemic treatment.
Okay.
That may be chemo, that may be targeted, that may be hormonal.
Okay.
Okay. Now the cycles are decided as per the evidence that is available. Okay. So what is evidence? So in large group of patients, there have been research done and they prove which is the best suitable way to tackle this type of tumor in this particular subtype and in particular stage.
Okay.
Clear? So if you have, say, a tumor which is locally advanced in a breast cancer which is hormone positive, HER2 positive, probably the best regimen is 6 cycles of a particular chemo known as TCH
Acha.
with P. So this is a chemo regimen name. So there you have 6 cycles. If it is not that subtype, if it's an HER2 negative subtype, then your regimen becomes 4 cycles of a chemo, say chemo A, and 4 cycles of chemo B.
Okay.
So this is all evidence based, and like we are thinking now, there have been scientists, researchers, they have put this thought process since decades, and now we have got those results, and we are implementing it in our practice. The guidelines that we usually follow are European, American guidelines. They are internationally accepted. And trust me, in a year, there are almost 20 to 24 iterations of these guidelines.
Okay.
So you can imagine that every 15 to 20 days, these guidelines are changing. So
How do you stay up to date?
Yeah, so we have app and everything. So we keep on reading. So it's a very engrossing field to be up to date with oncological advances. Not all may be implemented in real world practice, right? We have a lot of barriers.
Okay.
So newer medicines are costlier.
Right.
Their accessibility, availability is also a challenge.
Okay.
So though the guidelines update very fast, so there is always this gap probably,
Right.
where this could be the cutting edge, but we are here.
Okay.
That's not bad. That still propels us to do something better.
So every time these guidelines are revised, it is always becoming a little better.
Yes.
Is that what you're
Yes,
saying?
yes.
So every
So-
15, 20 days, you have advancements in the field of cancer.
Yes. So when a guideline is updated, it
Yeah.
is supported with a whole lot of data.
Right.
And that data should say that it is better than the standard of care.
Right.
Standard of care at that moment. And then the guidelines are updated.
Okay.
So it's a very meticulous thing that we follow.
So I mean, it all sounds really complicated to a layperson like me. How many cycles of chemo? What is the kind of cancer that you're talking about? What are the receptors? And I'm hearing all these words like targeted therapy and immunotherapy and all of this precision oncology. But I think the best thing to do is just trust your doctor. Put yourself in good hands and trust your doctor, the treatment course that the doctor decides. Does the patient also have a little bit of say in? I mean, are there options to choose from, A, B, C, or is it just that, okay, this is your cancer is equal to this is your treatment?
So there are options. I'll give you an example. Say, for example, CA ovary, ovarian cancer, developed in a young female. And now that female has not completed her family or something like that. So we have a situation where we have to give treatment, but we also have to do fertility preservation.
Right.
So how do we navigate that landscape?
Okay.
So definitely the patient has a say.
Okay.
Tomorrow, if you have a larynx cancer and the patient is a singer, then how do you do the things? Because if you don't treat it properly or you don't preserve the larynx, then his basic profession is going to get hampered.
Right.
So these definitely the patients guide the doctors as to what are their preferences, but definitely the way you treat should also optimize the outcomes.
Absolutely.
Right? So most of the times when the biggest hindrance that I face as an oncologist is to convince the patient that this particular treatment is going to be beneficial for you. See, like the barrier that you are having, or anybody who is non-medical background has to understand these factors, they kind of, typical example would be a breast cancer patient coming. She will say, मेरे XYZ माउशी वाउकरे, she also had a breast cancer, उनका तो 8 कीमो में हो गया.
Okay.
Why am I being told 16 cycles?
Okay.
उनका 3 हफ्ते में एक बार होता था. Why am I told a weekly regimen?
Right.
So that is because your type of tumor is different, right?
Right.
You have a triple negative breast CA, which has to be, which is a rapidly growing tumor as compared to the other ones. So you have to compress your regimen. So something we follow known as dose dense therapy. So the thing is that it's really important to understand that the doctor is trying to think or optimize your outcomes without taking too many risks.
So I would like to add something here from my personal experience, that when I came out on social media and discussed my disease, I got a lot of messages from people who are currently fighting breast cancer or people who have survived. And there were thousands of messages which I was reading every day, comments and messages on all my social platforms. One thing that I understood for the first time in my life as a layperson was that no two breast cancers alone are same. Everybody's experience is different, everybody's diagnosis is different, everybody's perception of the disease is different. So you cannot compare. And this is something I learned the hard way. So all I can say is that when your doctor is telling you this is the best treatment course for you, don't doubt him. And I also get messages which talk about the doubts that people have in their minds, like you're saying, why 8 and why not 12 or vice versa. I also get these messages asking me that you're a survivor, so tell me, my doctor is advising this, is this the best way? And I always tell them, I don't know, because my cancer was my cancer. My journey was my journey. You have to make your own journey along with your doctor. So I think what you're also talking about, doctor, right now is the treatment goals. Correct. That what is it that you want, that you expect from your life after your treatment is over, right?
So what I've experienced in my practice is that man is a social, that is humans are social animals, right? Like we like to interact or be in a group. What has happened is that because of this taboo that cancer is cancer, when this diagnosis is made, we start to feel alone. Yeah. And then we try to seek validation from whatever source we have or whatever.
Oh, that's a great point.
Right. So it's basically the feeling that why me?
Yeah.
Why is this only happening to me?
Yeah.
And then you try to validate and get in touch with people who have been through that journey.
Yeah.
To kind of know that is this the right way to go ahead. That is what you do. See, you're on a trek, right?
Right.
You have lost your way. There are 2 people approaching. You'll ask them, "Bhaiya, ye sahi hai ki nahi hai?"
Right.
Right. So you'll never you'll. So basically, it's like being on a journey, but feeling very lonely during that. So as a doctor, I always try to be very friendly to my patients, right? Whatever they say is definitely out of genuine doubts that they have. It's not that they want to ask, that's why they are asking.
Yeah.
ऐसे नहीं कि कुछ होते हैं जो पढ़ के आते हैं and so Google and all, it causes a lot of clouding in thought process. But 90% of the patients have really genuine doubts. They are experiencing it for the first time. It might be the 100th time for me, but for them it's the first time. I think that should be of value.
Right.
And any silly doubt has to be approached with utmost genuine sincerity, that I feel, so that it is answered to the best of their satisfaction. Though it takes time, but probably that is how my practice has been. So I try to ask or tell them, you write down your doubts, whatever it is, you WhatsApp me. Whenever I am in car, I can message them back.
Right.
But that is also very reassuring for them. So, but yes, I think what should change is that we should have many support groups which should address this. So there should be a clear conversation and it should not be a taboo. And I think that is precisely what we are working towards today, right? So we want to let this be a mainstream topic rather than a topic to be put behind or hidden in the shadows, right? So cancer is not a taboo. It's a definite, it's like any other disease that probably happens to the human body. And there are definitely ways. I will tell you, breast cancer, the treatment has grown so leaps and bounds. Probably 7 years or 10 years prior to this, the outcomes have been like tenfold better.
Okay.
We have been more meticulous in choosing patients who will require chemo.
Okay.
We have been more meticulous. So there is no blanket treatment now.
Right.
We are identifying a particular person's cancer, the precision characteristics that it has. And we are trying to make a tailored plan so that they reach the ultimate goal.
Right.
And that is basically how oncology is changing. So from the blanket treatments of XYZ number of chemos, now we are trying to precisely cater to that particular patient only. Though it's the same cancer, though it's the same stage, but tomorrow if a patient is say diabetic, his sugars are haywire, you cannot give certain drugs.
Okay.
You can avoid them. So we replace them. So that is how all the things are
So
changing.
I think the whole treatment course is
It is
designed,
becoming more patient-centric.
right, to make the quality of life better for this particular patient.
Yes, and that has improved the outcomes. Number of positive cases are more.
Yeah.
So the hope that other patients have is definitely on the rise.
And I think it's always more encouraging for other people as well. And to have that kind of doctor-patient relationship is going to, make a lot of changes to the whole cancer word.
Correct.
Association of fear with the word cancer.
True.
Right. And I also want to talk a little about the fear that is currently lingering in a lot of people's minds. So when I came out with my diagnosis, a lot of people in my community also wrote to me, why you? You are so fit. You go to the gym every day. You always eat healthy. You've never put on weight. And if it can happen to you, it can happen to me. It can happen to anyone. So that fear is constantly on the rise. But is that really something people should be worried about?
So let's take breast cancer for an example. We can discuss it for every other cancer also. But breast cancer, so every cancer to develop will have certain risk factors. Certain risk factors are modifiable, certain are non-modifiable. So what are modifiable? Those are in your control. Non-modifiable are not under your control. Okay. So in non-modifiable risk factors, if we see that being a female itself is a risk factor for breast cancer.
Okay.
Males, though there is male breast cancer in about 1% of population, males are less likely to get breast cancer. So you cannot change being a female, right? If you have a say family history, right, you have certain mutations known as BRCA mutations, BRCA mutations and all. So there, that is something that you are born with. You cannot change that. Right. So these are certain risk factors, or maybe we can take age. As you grow old, the chances of getting cancer is higher. Right. So these are non-modifiable risk factors that you have. Okay. Then there are modifiable risk factors, and that is where actual effort comes in. So what are modifiable risk factors for breast cancer? So one is weight.
Okay.
So
weight
now,
gain also can increase the risk?
Yes. So India is laden with obese people.
Yeah.
Obesity is an epidemic in India.
Okay.
Obesity or excessive weight can lead to certain hormonal changes, which can lead to increased predisposition to develop breast cancer.
Okay.
Then addictions, smoking and alcohol.
Okay.
Both are linked to increased incidence of breast cancer. Then for females, especially because of the lifestyle that we are having, we are pushing the age of marriage ahead.
Yeah.
The age of first pregnancy is late. Right. So that has been attributed towards higher.
What is late? How late is late?
So the
30
guidelines define 35 as the cutoff.
Okay.
30 to 35 has a higher relative risk, but more than 35 has a very exponential increase in the relative risk.
Okay.
Second would be nulliparity. That is, if you never had a child, that is also a risk factor.
Okay.
Then there are certain factors like age of menarche, that is the first attainment of periods, age of menopause. So these are also factors that influence. So basically, breast cancer is a very hormone dependent cancer, we can say, and that's why so much hormonal therapy and all is usually there in breast cancer. And the number of years in which the female is under the influence of these hormones, that predisposes you more towards breast cancer. So now these are some things that we cannot change.
What about diet?
Diet. So again, diet is associated with obesity. So if you have high calorie diet, fast food, that can put on weight and that can lead to higher incidences of breast cancer.
Okay.
So nowadays we are in an era where we are surrounded by carcinogens, the air we breathe.
Pollution, yes.
Pollution. So there are multiple things, but there are few things that we definitely can do. Like you said, exercise.
Yeah.
You can be of a healthy weight.
Right.
Avoid fast food, avoid high calorie foods. Try to have a balanced diet, a healthier lifestyle, maybe exercise 3 to 4 days a week.
Yeah.
As per WHO, about 3 days moderate intensity exercise is also sufficient to prevent cancers. So definitely dwell on things that can be changed, that can be improved. And then once you have done that, or once it happens in parallel, but then you have to also focus on early detection.
Early detection, yes.
Right? So one is to prevent.
Yeah.
That is known as primary prevention.
Yeah.
Then you have secondary prevention, that is early detection.
Right. So primary prevention
is like all these things, risk factors, understand what you are prone to and try to correct it, whatever is in your hand.
Right.
Then you go for screening methodologies.
Right.
Say for breast.
I know for a fact that my cancer was completely cured because it was detected early.
Perfect,
so I know that the importance of detection is very, very, it's all there in your face. So tell me, what are the screening options?
For breast cancer, the screening options is that as per guidelines, by the age of 40, every year after the age of 40, you should do a mammography testing.
Okay.
So that mammography is a screening mammography.
Okay.
Our screening mammography is different from the normal mammography in a way that it's a low dose radiation exposure. Now that screening mammography has a sole purpose, only one purpose, to check if there is abnormality or not.
Okay.
It does not characterize kya hai, kaisa hai.
Right.
So it will just tell you, should you go for the full-blown mammography? No, full-blown mammography.
Okay.
Now full-blown mammography will have a compression view.
Okay.
It will have 2 different types of views to localize the lesion. So that is a more detailed investigation.
Okay.
So screening में क्या पता चलेगा कि just whether it looks extremely okay or if there is suspicion.
Okay, but what about even younger girls who are getting breast cancer nowadays?
Correct. So mammography is not very sufficient in that, because in younger girls the breasts are very dense. So an X-ray mammography does not help.
Yeah.
A sonomammography can be done.
But talking about younger cases of breast cancer, do young girls also need to keep testing themselves again and again? What are the early symptoms to look out for?
So for them, as per guidelines, from the age of 18, you have to do something known as self-breast examination.
Okay.
So it's a 4th or the 5th day after your periods, you examine the breast yourself.
Right.
Every month.
Anything, any changes
any abnormality.
Right.
What it does is that it sensitizes you towards changes.
Right.
So 2-3 महीने आपने check किया, everything is okay, and now you are developing something new. Now it could be something simple as an infection or a folliculitis or something like that, but you have picked it up.
Right.
If you have picked it up, it is very high likelihood that you will go and show a doctor. ठीक है?
Right.
And then you will have maybe an early diagnosis. ठीक है? So there are studies that have shown that self-breast examination is very helpful. There are studies that have shown that it does not lead to a lead bias or a lead period to diagnose it very early. But it's a simple thing that can be done. I advise all my patients to do self-breast examination from the age of 18.
Okay. And doctor, you're talking about screening. We also hear testing for cancer. So screening and testing same things, or are they different?
No, screening and testing are different.
How?
So screening is done in asymptomatic individuals.
Okay.
What I mean by that is that I am a normal person. I don't have any symptoms.
Okay.
But I still go there and check myself to see if there is something lurking which I don't know. So that is screening. Okay. In cancers, we usually screen for 2 female or women related cancers. One is breast and second is cervical cancer.
Okay.
For males, we check for prostate cancer and colon cancers.
Okay.
So there are specific guidelines for each of them. So basically screening is where you are not symptomatic.
Acha.
And that screening test should also give you a head start towards detection.
Okay.
There are certain cancers like ovarian cancer, you cannot screen for them, because even if you screen, there is very high likelihood that that screening test may not pick up, or it is not very sensitive,
Okay.
so that you get an head start.
So what do you need to do for that?
So for that, actually what they recommend is do normal health checkups, maybe a sonography, and be in touch with your doctors. And once the screening test detects it, you can get a head start. So that head starts, by head start I mean that you can start your treatment early, and that leads to a better outcome
Okay.
in the end. So the screening test actually has benefited you.
Okay.
And every person should undergo these screening tests.
Okay.
Screening for cancer. So mammography after the age of 40.
40.
Pap smear by females every 3 years. Once every 3 years from the age of 30.
Okay.
That is usually the screening for females for cancers.
That's a lot of food for thought, actually. And we also hear about a lot of cases of recurrence. The whole treatment is done and you're cancer free now, and suddenly it recurs for no reason. So what kind of treatment options does a patient have in order to ensure, or at least try their best, that the recurrence doesn't happen?
Correct. So their treatment protocols have been devised in such a way, most of the patients, where you will have a period where you receive intensive chemotherapy or intensive treatment, and then you have something to follow it up, like a maintenance regimen. That has probably come up in most of the breast cancer subtypes that we discussed earlier. So if you have an hormone positive breast cancer, then you have something known as hormonal tablets, which are as per guidelines to be continued up to 5 to 7 years
Okay.
after completion of the primary treatment.
So I also want to ask you that, as somebody who lives in a metro city, I know that there are all these treatment options available, but what about the treatment options available in rural places in the country?
Correct. So I think in the previous or the first question when we were discussing, I said that accessibility is a big challenge, especially in the landscape like India, where most of the treatments are available, but they are not accessible to everybody. So I think even government is making really good efforts. There are certain private entities that are making efforts to have outreach centers so that they can cater to these populations also. So I think it is a collective responsibility. One is to spread awareness. Second is to facilitate accessibility to treatment. That can be in many ways. So it can be in ways where probably the doctors can visit that place, have some camps, or patients can be got to the hospital so that they can get the necessary treatment. And basically it has to be a slow but a definite effort towards the goal of cancer care for all.
Okay, coming back to breast cancer, let's talk a little about male breast cancer. It's not something which is spoken about.
Correct.
I think it's not spoken about at all. And a lot of people still believe that males cannot get breast cancer.
Correct.
So what is the percentage of males that can get breast cancer in our country? And how does a male identify that, oh, I have breast cancer? What are the symptoms to expect?
So about 1% of the total breast cancer patients would be male patients.
Okay.
And the symptoms are exactly the same. Lump, discharge, a lump in the armpit, changes over the skin, nipple retraction. Usually these are confused with gynecomastia.
What is that?
So gynecomastia is male breast enlargement.
Okay.
That can happen in usually the pubertal age group, where the boys are maturing towards being a man, and sometimes in elderly patients where the testosterone levels fall down.
Okay.
But in certain cases when these processes are happening, again you can associate that these are hormone related processes, like puberty, from a boy you are becoming a man, or an elderly patient where your testosterone levels are...
This must be something which goes away as you...
Gynecomastia is something that has to be identified and treated.
Okay.
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 So any breast enlargement, if or most of the times it could be painful. Gynecomastia is usually painful, but if you have a painless lump,
Okay.
or you have something that is over a long period of time, it is growing, it's hard, then that could be male breast cancer. Usually male breast cancers are hormone positive breast cancers, which typically tells that these are hormonal things that have led to this type of change. Again, early detection is the key.
Right.
And going to the doctor immediately or as soon as possible, as soon as you identify that this is something not usual,
Right.
helps early detection of male breast cancer.
And why people want to run away from the word cancer? There is so much fear around it. And we know that early detection is key. We know that there are so many treatment options available. And yet people just don't want to admit or even try to diagnose themselves, go to a doctor to know that they have cancer. There is so much fear around it. So what can we do to sort of do away with that fear?
Correct. So I'll just tell you a case or one of my patients. So she presented with back pain. Okay. She was being evaluated for back pain at the local hospital. An MRI was done, and MRI picked up that the vertebrae had collapsed, and this lady was about 38-40 years old.
Okay.
Subsequently, when that MRI was done, then the lady said, and she was so at that time the lady said that she also has a lump in the breast.
Oh.
And that was a huge lump, about 6 centimeters.
Okay.
Now you can imagine that the lady did not come upfront that she has a lump in the breast. And that
But
could
the
be
back
because
pain
of
was bothering her all the time.
more, yes.
Right.
And that could be because of maybe a social stigma where maybe she could not tell somebody, maybe she could not have that support structure. So she was from a lower middle class society, family, and so there are multiple implications when you have these things. Tests are there, so the cost of the tests are there. Then you're always busy with your children and other routine daily stuff that you hardly find time for yourself.
Absolutely.
Right? To go to the doctor and at least ask, is this bothersome? And if it is not troubling, we tend to ignore it.
Absolutely.
कुछ हो नहीं रहा है तो देख लेंगे, बाद में देख. Then that comes as a really big shock when you have something like a back pain and vertebral metastasis. I'll be very glad to tell you this patient I saw in about 2018 and 19. So we gave radiation to her bone metastasis. It was luckily identified as a hormone positive tumor, though metastatic. She had a lot of disease burden. If I show the PET scan, it was almost disease every single place in her body.
Okay.
We started her on chemotherapy. About 18 weeks, she took the chemotherapy cycles. Then we shifted her to hormonal therapy with certain newer medicines known as target therapy tablets. The lady is fit now. She comes to the OPD regularly. This is almost like 7 years now. She's in the 7th year. She comes walking.
Okay.
This lady had vertebral metastasis. She was bedridden. We had to radiate her spine. But that is how the treatment has changed. If you see the PET scan, trust me, there would be 10 doctors which would have told her that this is the end stage, last stage, and advise the family कि घर पे जाके सेवा करो.
Okay.
In a 40-year-old lady, it's unimaginable.
Right.
But there are ways to come out of this. If you have the right guidance, right time, you start the treatment, take it properly, you can have a very good outcome.
Okay.
Right? So the point I want to make is that one is seeking medical help. That should be encouraged. In family, especially the husbands, the male person in the family, he should be more attentive towards these kind of symptoms. There should be a clear conversation that should happen. Most of the times I have seen that females don't, or they cannot tell their husbands also very clearly that what is happening.
Right.
And this is not, I'm not talking about the elite class of society. I'm talking about the normal people. So I think that taboo should go away. It is going away gradually with more access to information, with more awareness campaigns. But that has to be manyfold, right? And there are a number of treatments that are there. Even I feel doctors, the general practitioners and the family physicians, sometimes they also have a slight bend towards negatively viewing an advanced cancer case.
Okay.
So sometimes what happens is that these patients may not directly come to a specialist, right? So they have to be guided properly, and there should be a channel that they can follow to approach the right person at the right time. The other thing I would like to stress is that it's very imperative that hope is always there. In my practice, I personally don't like to use this is last stage of cancer.
Yeah.
Right? Stage 1, stage 2, stage 3, stage 4, they were determined for prognostic and treatment decisions.
Absolutely.
Stage 4 के आगे कोई stage आता नहीं है, इसका मतलब ये नहीं कि ये last stage हो गया.
Correct.
Because in our minds, we process it like this is the last for the patient.
Okay.
The patient has reached his end,
It's
or
basically to help you decide what the treatment
it's
course
for
is
my
going to be.
decisions.
Right.
That does not mean that the patient, now see, for the case that we discussed, so she was by definition the last stage, the 4th stage.
Right.
7 years now have passed. She's coming walking, she's living her routine daily life, she takes her children to the school, she's very happy. The pain has disappeared, she's taking these tablets. So that is how oncology has changed, and that this message should go out.
Yeah.
Right? That आखिरी stage है करके सब हाथ पे हाथ बांध के बैठने का नहीं है.
That time has gone.
That time has gone.
Yeah.
ठीक है. Though the treatments might be a little expensive, but there are ways to navigate those hurdles.
At least there are options.
Yes.
And the fear doesn't have to be there in the minds of
Absolutely.
people. And what is required is more conversations around it. So it doesn't have to be such a taboo, and it doesn't have to be such a scary word anymore. And thank you for sharing that that case with us, because it does give a lot of people a lot of hope.
Absolutely.
So we've already spoken about a lot of things, doctor, but before I leave you, would you please tell us 3 do's and don'ts to avoid cancer?
Okay. So it's a very extensive and exhaustive topic, but 3 do's and don'ts: keep a healthy weight, exercise, be away from addictions. I'm not saying addictions in a sense where be away from tobacco and alcohol as much as possible. The third would be aware about how to prevent yourself, how to get yourself early detected if you have the cancer.
Yeah.
Right? So a healthy lifestyle to check your weight, exercise. Second, a diet, proper diet. Then avoiding carcinogens or things that make you more prone to get cancer. And the third would be to follow the screening guidelines,
Right.
be aware about how to detect and how to get the tests done. So I think these 3 are the do's and the don'ts. I think don'ts mix ho gaya.
Don't not do them would be the don'ts. Don't start consuming alcohol and
True.
smoke, and don't start consuming junk food. So that's a lot of food for thought for us, doctor. So thank you so much for giving us so much information. And to all of you, I would like to leave you with the thought today that why cancer happens, nobody knows. And I think the question is not why me. The question is how I can safeguard myself from a cancer to attack me in the near future or any time in the future. So please get your tests done regularly, and as doctor said, do all the do's that he spoke about. Have a healthy lifestyle and avoid all kinds of addiction. And for more such content, follow us on our social handles and check out our microsite. Thank you so much.